Help is doing trainings and consulting projects. And we have various types of trainings which are around quality and the technical parts of the laboratory. And we have certain consulting projects which we are doing across the globe. 360 Health has come out with their laboratory services, and it's a different model collaborating the labs all across and creating a repository of patient data and giving a networking platform to all the healthcare stakeholders. So we are NABET accredited since 2015, NBQP 2017, and our labs are NABL accredited. These are few pictures which you can see of our groups which we have done trainings for. Myself, I'm Dr. Jatinder Bhatia. I'm Director with 360 Diagnostic and Health Services, and I have 30 years of experience in pathology as a director and as a part of management with various national chains, and have done few international projects also. And coming to our faculties today, Dr. Rupali Suryawanshi, she's a consultant microbiology, Ruby Hall Hospital, Pune. She's MBBS, BJMC, Sasun Hospital, Pune, MD Microbiology, SAT, GSM, MC and Chem Hospital, Mumbai. She's worked as an assistant professor at SAT Medical College and KEMH from 2009 to 17. She's director and head of the operations Microcare Diagnostics Lab, Pune, and also consultant microbiologist at Ruby Hall Clinic, Pune. Areas of interest are tuberculosis and infection control. So she'll be talking about the microbiology part, how laboratory investigations in micro and serology we have to work around COVID. So let me introduce to the other speakers also. We have Dr. Reema Bahri with us, who's MD Biochemistry, and she's consultant and head of clinical biochemistry with Batra Hospital, Delhi. She's MD Biochemistry, awarded 50 most impactful quality professionals at World Quality Congress, Mumbai, NABL lead assessor, NABH assessor, CAP inspector, consultant trainer, auditor for accreditation with NABL, NABH CAP. She is former head of the quality assurance with SRL, Mumbai, and she was looking after all the labs across SRL group. She was former in charge clinical biochemistry at Mamta Labs, Hyderabad, faculty with medical biochemistry, MBBS, MD, BDS, science students. She's member QCI, CLSI, and she's also life member with the Association of Medical Biochemists of India, a regular speaker with national and international conferences. We have another eminent hematologist with us, Dr. Mamta Soni. She's a senior consultant at HOD Hematology and Clinical Pathology with Apollo Hospital, Chennai. She is again a gold medalist, so we have a lot of gold medalists today with us. Certificate course in Clinical Laboratory Management from IIM Ahmedabad. She has more than 19 years of experience in laboratory, impaneled with NABL as lead and technical assessor. All the three speakers are assessors with NABL. Principal investigator for multicentric studies on malaria and artificial intelligence. Faculty and examiner for DNB students and also for Allied Health Sciences Apollo Hospital. She's quality manager with Apollo Hospital. Areas of interest are hemostasis, thalassemia, hemoglobinopathy flow cytometry, and she has 8 publications and various posters and presentations to her credit. She is reviewer of various international journals. So I welcome my faculty for today's program. We are open with the platform. We'll be starting with Dr. Mamta Soni with her first presentation about the hematology, and stay tuned with us.
Dr. Bhatia, is my presentation visible? Shall I start?
Yes.
Okay. So good afternoon.
You can carry on.
So basically, I would be focusing on the hematology and COVID-19 infection. As most of us know, COVID-19 is an infectious disease caused by SARS-CoV-2, that is severe acute respiratory syndrome coronavirus 2. This virus was first identified in December 2019 in Wuhan province of China and has since then spread globally, resulting in the ongoing pandemic as announced by WHO.
Little louder. Yeah.
Is it fine now?
Yeah, better. I know COVID has given us a lot of learning in newer methods. I think all of us have become IT experts suddenly. Yes, Mamta, please carry on.
Yeah. So now as any other disease, the
It
contribution.
was better in between. You can just keep your mic in front. Yes,
Yeah.
like this. Better.
As any other disease, the contribution of laboratory towards management of COVID-19 is immense and very strong, and it is involved in almost all aspects of management of COVID-19. But I would like to say one thing now, that as the world is experiencing the disease for the first time, the knowledge on this disease is evolving and is changing every day. The information shared, which I'm sharing here, is based on the current knowledge and is dynamic, and it will keep evolving as more experiences and the publications filter in. So basically, the influence, contribution and influence of laboratory in COVID-19 is for screening for diagnosis, monitoring the. Start with the laboratory contribution towards screening for diagnosis, monitoring the evolution and complications of disease, treatment decisions, monitoring of treatment and prognosis, and I would speak on the hematology contribution on all of these. Now, screening for diagnosis, a simple test like CBC reveals lymphocytopenia in many of the cases. And this lymphocytopenia, it's important for us to keep the timelines because it is more pronounced between day 7 to 14 of infection. Now, lymphocytopenia is nothing but the lymphocyte count lower than the age appropriate reference interval, which is less than 1000 cells per CUMM in an adult. It is also a risk factor for progression to severe disease, so monitoring the trend of lymphocyte count is very important in this disease. Neutrophil lymphocyte ratio more than 3.13 is an independent risk factor for progression to a severe disease. Now, what causes this lymphocytopenia, which is kind of the most predominant common hematological finding? For this, we have to know a little bit on the pathogenesis of this virus. This COVID-19 virus enters the host cell by attaching to the ACE2 receptor of the host cell. And the protein, which is like TMPR SS2, the spike protein of SARS-CoV-2 is primed by this particular protease, which is transmembrane serine protease 2. Now, what happens is that lymphocyte also expresses ACE2 receptor on their surface, and virus may directly infect these cells and ultimately lead to their lysis, leading to lowering of the lymphocyte count. Other cause of lymphocytopenia and the pathogenesis of this disease is the cytokine storm, which happens eventually in a very severe progression, which is characterized by markedly increased levels of interleukins and some tumor necrosis factor alpha, which may promote lymphocyte apoptosis. Also, substantial cytokine activation may be associated with atrophy of lymphoid organs, especially spleen, and it further impairs the lymphocyte turnover. Now, in a special case like cancer patients who are at increased risk for complications from COVID-19, there is a coexisting lactic acid acidosis which also inhibits the lymphocyte proliferation. So, these are the predominant causes by which lymphocytopenia happens in COVID-19 patients. In peripheral smear, these I have not seen in many of the cases, but few of the cases show apoptotic hypolobated neutrophils, reactive lymphocytes, and RBC fragments in case of DIC and sepsis. So, not very pathognomic findings in the peripheral smear. Now, coming back from the screening to the diagnostics, now when we have a patient who is presenting to us in a fever clinic or an OP with suggestive COVID-19 symptoms, chest X-ray findings, and lymphocytopenia on a CBC, it is kind of this patient is categorized to be a suspect of COVID. Now, what we have to do, we have to diagnose the patient. As we all know, the only diagnostic test as recommended by ICMR and WHO is RT-PCR of respiratory sample, the OPS and the NPS, that is oropharyngeal swabs and nasopharyngeal swabs from affected patients to identify the presence of the virus, and also the detection of antibodies, which is not for diagnostic purposes as of now, as recommended by ICMR. On this, I think my microbiology co-speaker will elaborate. But diagnosing COVID also helps in epidemiologies for case tracking, contact tracing, and containment of outbreaks. The third contribution of laboratory towards COVID-19 management is very important. I would say the most important, which is monitoring evolution and complication of diseases. Now, the most fatal complication of COVID-19 hematologically is CAHA, which is COVID-associated hemostatic abnormality. The hematology lab has a strong influence on the management of this CAHA, which has both hypercoagulable states resulting in VTEs as well as DIC-like condition. And postmortem findings in patients with COVID-19 also show typical microvascular platelet-rich thrombotic depositions in small vessels of the lungs and some other organs. So hematology lab contributes towards complication monitoring of CAHA by monitoring the hypercoagulable states in the form of D-dimer monitoring, PT, PTT, fibrinogen, and platelet count. And of all these parameters, the most important is D-dimer. And there are several papers which say that the cutoff of 1.5 microgram per ml for predicting venous thromboembolism has demonstrated sensitivity as high as 85% and specificity of 88.5% and a negative predictive value of 94.7%. PT prolongation more than 3 seconds points towards a hypercoagulable state, and we should keep in mind that we should be seeing the PT and not the INR, as subtle changes might go undetected when the prothrombin time is expressed as INR. PTT more than 5 seconds, fibrinogen is high, and platelet count invariably is increased when the patient is entering into a coagulopathy of a hypercoagulable form. Now, what causes this hypercoagulable state in a patient of COVID-19 infection? Basically, like any other disease, prolonged immobilization, dehydration, acute inflammatory state, those are the risk factors. Other than that, there are presence of other cardiovascular risk factors like hypertension, diabetes, obesity, or cardiovascular diseases like coronary artery disease, history of stroke, peripheral artery disease, previous history of VTE and classical genetic thrombophilia such as heterozygous factor V laden mutations, endothelial cell activation and damage due to the virus binding to ACE2 receptors, release of a large amount of inflammatory mediators and the application of hormones and immunoglobulins in severe or critically ill patients, causing an increase in blood viscosity leading to hypercoagulable state. Vascular endothelial damage induced by mechanical ventilation as a part of treatment, central venous catheterization, and surgery. The combination of all these factors may lead to a DVT occurrence or even the possibility of a lethal pulmonary embolism due to thrombus migration. Now, the second aspect of this CAHA, which is COVID-associated hemostatic abnormality, is entering into a DIC. But this DIC in a COVID-19 infection is slightly different than the DIC which we see in sepsis. In sepsis, the thrombocytopenia is usually more profound and the D-dimer concentration do not reach as high levels, as high values as we see in COVID-19 infection. So basically, a much higher D-dimer and a much lesser thrombocytopenia are the hallmark for a DIC in COVID-19 infection. And for DIC, since I think 2006, we have been doing the ISTH scoring system, which is designed by the Subcommittee of Scientific and Standardization. And they have recommended the use of scoring system, proposing a 5-step diagnostic algorithm to calculate a score. And this score is based on some very simple laboratory tests which are available in almost all the hospital-based laboratories like platelet count, PT, fibrinogen, and D-dimers. And the requisite is that there has to be a presence of an underlying disorder known to be associated with DIC to enter into this algorithm. So based on the values of platelet count, PT, fibrinogen, and D-dimers, we give a score. If the score is more than or equal to 5, the patient is into over DIC. If the score is less than 5, then the patient is in non-overt DIC. If he is in overt DIC, we have to do the scoring daily, and if he is in non-overt DIC, we have to repeat the scoring after 1 to 2 days. So the management of DIC remains the same in COVID-19 infection, the scoring system. Other than that we have to keep in mind that thrombocytopenia may not be very profound and the D dimer would be highly elevated in COVID-19 infection. Now, this slide I got from my clinical hematologist colleague, Dr. Prabhu, who is going to have a presentation from 4 to 5, and I found it very interesting because it speaks, again a proposed criteria, and it talks about the stages of coagulopathy, stage 1, 2, and 3, on the basis of total lab parameters. So we can see the immense contribution the laboratory is having in management of CAHA, that is on D-dimer, platelet count, PT-PTT. Stage 1, we can do a ward management. For stage 2 and 3, the patient has to be in ICU, and there are so many diagnostic questions like role of other lab biomarkers, significance among outpatients, and also many therapy research questions on this. But this particular thing is evolving, and it is only as of now proposed. After the management of CAHA, which is the most fatal complication in COVID-19 infection, certain other complications also can happen, and where also a hematology laboratory has its contribution in monitoring it, like heralding of a bacterial infection. CBC shows leukocytosis and neutrophilia, and of course, there would be some peripheral smear findings in the form of toxic granulation, Rowley bodies, maybe fragments. Then, of course, in microbiology, they have to do a blood culture, 2 sets of antibiotics started, procalcitonin, and multi-organ dysfunction, which is kind of a final complication of the disease, can be monitored with the help of other lab parameters other than hematology, like liver function test, renal function test, CRP, LDH, ferritin, CPK, TROP-T, etc. After that, now we have done the screening for the diagnosis, we have diagnosed the disease, we have monitored the evolution of complications in the disease, and now comes the treatment decisions, where again, hematology lab has a role to play. D-dimer, on the basis of D-dimer values, the decision is taken whether a low molecular weight heparin has to be indicated in the patient, and it is indicated in patients with very high D-dimer levels, more than 6 times of the normal. Am I audible?
Yes, yes, please carry on.
Second parameter which helps in the treatment decision is the platelet count, where it says that the prophylactic dose of low molecular weight heparin for a severe disease is recommended unless there is an active bleeding or a platelet count of less than 25,000. So a platelet count has to be seen before we start a prophylactic dose of LMWH, and if it is more than 25,000, then only it should be indicated. If it is less than 25, we should not start LMWH prophylactically. After the treatment, the fifth aspect of laboratory contribution to COVID-19 management, which is monitoring of the treatment. Monitoring of the treatment is done with the help of D-dimer values, prothrombin time, and platelet count, where it helps to monitor low molecular weight heparin, consider and investigate heparin-induced thrombocytopenia, even if the platelet count is in the normal range but has decreased more than 50% in the 4 to 14 days of commencing the heparin treatment. So it's important, that we should not just feel that, okay, platelet count from 4 lakh, if it has come down to 1.75, it is important that we investigate for heparin-induced thrombocytopenia in this patient. The final laboratory contribution is on the prognostication of the disease. I'm just talking about the hematology aspect. Lymphocytopenia is a risk factor for progression to severe disease. So monitoring the trend of lymphocyte count is extremely important. Neutrophil lymphocyte ratio, which is just derived from the CBC parameters, is derived from our differential counting, is independent risk factor for severe disease if it is more than 3.13. Platelet count, though till now it has not been proven to be a very robust prognostic criteria, but still in my experience I have found that the 2 patients who had severe thrombocytopenia in our setup did not do well at all. Then interleukin 6, which is indicative of the cytokine storm, NT-proBNP, and the coagulation parameters, which I have discussed in details, indicating DIC and hypercoagulable state, help to prognosticate COVID-19 infection. This is just a summary of the basic hematological markers, some very basic tests which are available in all the hospital-based laboratories and their clinical significance, like lymphocytopenia is indicative of a defective host response. Leukocytosis tells that there can be a bacterial superinfection. Neutrophilia, again, bacterial superinfection or a cytokine storm. And coag parameters, thrombocytopenia, prolonged PT, prolonged APTT, increased D-dimer, FDP, all are indicative of an impending CAHA or a coagulopathy. Now, there are just a couple of slides upon the few patients which we got here. I've done a result analysis totally on hematology parameters in 50 patients. And we found that almost 58% of these 50 patients who were admitted had elevation of D-dimer, and out of these 58%, 55% had severely elevated D-dimers. So the mild elevation is like up to 3, moderate elevation is more than 3 to 6 times, means 3 to 6 times, and severe elevated is more than 6 times from the baseline values, that is less than 0.5. PT-PTT actually did not show us any much significant results in terms of prolongation. Only 20% of the patients had an elevation of PT and 18% had an elevation of PTT. Total WBC count was most of the times normal, and there was a leukocytosis which was observed in 32% of the patients. The most significant finding was the neutrophil lymphocyte ratio, which was elevated in 62% of the cases as they presented to us. Lymphocytopenia was present in almost all other than 3 of these patients. So 3 elevated NL ratios were because of the increase in neutrophils and not because of the reduction in lymphocyte count. And every patient which had a lymphocytopenia had an elevated NL ratio. Platelet count again was most of the times normal. Only 22% of the cases it was abnormal. Out of these 22%, 63% was an increase in the platelet. And thrombocytopenia was observed in few, that is total 4 of the total 50 patients which we had a reduction in platelet count, out of which only 2 patients showed a intense thrombocytopenia or severe thrombocytopenia, and both the patients with severe thrombocytopenia had severely elevated D-dimer and NLR's elevation also, and they did not do well. Other than these contributions from the hematology laboratory towards the screening of diagnosis, treatment decisions, monitoring of treatment prognosis, there are certain additional investigations which can be taken up in future. As of now, we don't have much data on them to kind of indicate their importance. Something like a tissue plasminogen activator, because fibrinolytic activity is quite pronounced in CAHA. Few papers have also suggested that lupus anticoagulant is positive in COVID-19 infection, but people are not ordering this investigation as of now, so we do not have much data at present on the contribution of lupus anticoagulant towards the disease. Investigation of HIT is again something, as I elaborated already, should be taken up if there is a significant reduction in the platelet count. CD4 CD8 ratio will help us it will throw some more light on the lymphocytopenias. VWF and ADAMTS, especially to kind of differentiate a DIC from a TTP. Then neutrophil CD64 expressions, mean cell volume of neutrophils and monocytes, immature granulocyte fraction, delta neutrophil index, and monocyte distribution width. They would all help us to see if the patient is going into sepsis. And then something as simple as application of data derived from CBC to derive formulas such as neutrophil lymphocyte ratio, which is already very much in use, platelet to lymphocyte ratio, monocyte to lymphocyte ratio. All these can act as surrogates to assess the extent of systemic inflammation. So these are the tests of the future, and I'm sure the way we are getting the cases, we will have some data ready on them in some time. Just a couple of words on the safety aspects, because everybody is kind of really concerned that whether they're going to get the infection, if they have a COVID positive patient, if they have a COVID positive samples coming to them. So it is noteworthy to know that predominant route of spread of COVID-19 is respiratory, but approximately 1% of blood specimens tested by RT-PCR had evidence of COVID-19 viremia. So although rare, infection through contaminated blood is possible, so we have to exercise extreme precaution. As of now, whatever data is available, a personnel in hematology lab is still at a lower risk of getting the infection compared to microbiology and molecular lab, but still personal protective equipment is a must while dealing with these samples. The last slide of mine is just the conclusion of whatever we have kind of discussed. COVID-19, though it is primarily manifested as a respiratory tract infection, there is a lot of emerging data which indicates that it should be regarded as a systemic disease involving multi-system cardiovascular, respiratory, GI, neurological, hematopoietic, and immune systems. Careful evaluation of laboratory indices at baseline and during the disease course can assist clinicians in formulating a tailored treatment approach and promptly provide intensive care to those who are in a greater need. So the role of laboratory is immense in the management. Preventive measures for thromboprophylaxis and early identification of potentially lethal complications, including DIC, will improve patient outcomes and will probably reduce the death rate overall and among infected patients without significant comorbidities. So that's all. I think with this I finish my presentation. I'm thankful again to 360 and to my department colleagues, team of doctors, technical staff, and all the attenders. So thank you all.
Thank you so much, Dr. Mamta. I think you have touched all the aspects of hematology in all the stages of the COVID, starting from diagnosis till monitoring. And we'll take the questions in the end. There are certain questions which are there, but we'll take them in the end. So you can stop sharing your presentation.
I did that.
And I request audience that please don't share in between. I can see some people, they are sharing their presentations in between. My request is that please don't do that. It disturbs the flow of the presentation. Thank you so much. And now I request Dr. Reema Bahri to please take over and discuss the biochemistry part of the investigations, how we are looking at it in COVID patients. Yes, Dr. Reema. Dr. Reema, we can see your slides. Please unmute yourself. Dr. Reema, you're muted. Please unmute yourself.
Dr. Reema, you want to unmute yourself?
Yes. Please unmute yourself, Dr. Reema.
Yeah.
Yes, now it is okay.
Am I audible now?
Yes.
Yes, you're audible now.
My presentation is visible?
Yes.
Yeah, it's on slide number 5. You may want to start from.
Yeah, I'll just start. I started without unmuting.
No worries.
I'll start.
Thank you.
Okay. Good afternoon, everyone.
Yes, we can hear you. We can see the slides. So you please carry on.
Okay. Thank you, Dr. Bhatia, for giving me this opportunity and for the nice introduction given in the beginning. And this is the place where I work, Batra Hospital. This is the picture of the hospital, and our hospital has been designated as a COVID hospital, part of the hospital we have designated. So straight away coming to the coronaviruses, I'll just slightly touch. This is a highly diverse RNA viruses of coronaviridae family, divided into 4 genera: alpha, beta, gamma, delta. And mostly these coronaviruses affect the animals, although they are zoonotic, but they can be transmitted between animals and humans. Typically, endemic alpha beta human coronaviruses can cause influenza-like illness or pneumonia in humans. However, 2 zoonotic viruses have emerged, causing severe disease in humans in the last 2 decades. One occurred in 2002 and 13 in China. That was SARS-CoV, which was transmitted from the civet cats. And again in 2012, MERS-CoV occurred in Saudi Arabia, which was transmitted from dormitory camels. The latest edition was COVID-19, which occurred from the local food wholesale market in Wuhan, China, where live animals on sale indicate possible animal-human transmission, and more recently, the human-human transmission, which has occurred. And on 11th February 2020, ICTV named this virus as Severe Acute Respiratory Syndrome Coronavirus. called SARS-CoV-2, and WHO named this disease as coronavirus disease COVID-19. And for all communication purposes, this virus is referred to by WHO as COVID-19 virus. So in total, 6 known coronaviruses have been known and 3 outbreaks. This is a picture of zoonotic corona infection from a primary and secondary host. This is not of COVID-19 as such, but of corona infection. And we can see a host of animals and infection being transmitted to humans. And this picture I've picked because we've seen the typical picture which all of would have seen, but this is just to show that coronaviruses are the largest RNA viruses, and amongst all the RNA viruses ranging from 27 to 32 kb, and it has spike-like glycoproteins on their outer surface, giving it a crown-like appearance. And the word corona comes from the Latin word which means crown, and I'm sure nobody wants this crown, and I don't know how this name came, but nobody wants this crown. And this COVID-19 transmission occurs via respiratory secretions, and COVID-19, the infection occurs in 2 ways. Everybody knows from direct close contact within 1 meter distance, or indirect sometimes from, droplets surviving on because the droplets can survive on clothes and surfaces since many days. So it could occur from touching one's mouth or nose, or by contact. And incubation period varies from 2 to 14 days. And severity of symptoms could be from asymptomatic to mild to severe. And why I'm talking about this, because I'm going to share some of the cases in our hospital which have occurred, And so very mild symptoms to asymptomatic to severe disease symptoms, from difficulty in waking up and confusion to severe chest pain and kidney failure, or extreme weakness and stroke and encephalitis and even myocarditis. I saw some of the questions coming up also. And specimen is typical CDC recommended specimen of nasopharyngeal and oropharyngeal specimens. And in our hospital, as patient self, we do fill a patient self declaration form and an ICMR specimen referral form, which is filled because currently we are outsourcing samples to a referral lab, and so therefore we fill this form. But shortly we are going to start testing in our molecular microbiology section under Gene Expert, and we'll be applying for NABL accreditation for the same. Now, coming to the role of clinical laboratories in monitoring COVID-19, biochemistry monitoring of COVID-19 is very essential, not only for diagnostic purpose, but it extends beyond it. And that is for disease progression as well as for severity, which is important for therapeutic intervention. Several common in vitro diagnostic tests have been implicated in unfavorable COVID-19 progression, providing important prognostic information. A recommended test list is required, and patients with severe COVID-19 could be at risk for cytokine storm syndrome. And cytokine tests, particularly interleukin 6, should be used where possible to assess severe patients suspected of hyperinflammation. The role of lab diagnostics is very essential in severe SARS-CoV-2 infection. My microbiology friend I'm sure Dr. Rupali will be talking about it more in detail, about the NAAT tests and the various other antibody tests. I will like to speak about potential clinical and biochemical significance of abnormal laboratory values in patients with coronavirus disease 2019. And so in viremia, there is increased value of CRP. Procalcitonin also rises because of bacterial superadded infections, and there is increased value of LDH because of pulmonary injury and widespread organ damage. Aminotransferases have been typically seen because of liver injury, and so the bilirubin. And BUN and creatinine values rise because of kidney injury. Because of cardiac involvement, there is raised values of cardiac troponins and other cardiac markers, and impairment of liver function, there is decreased value of albumin. Now, this is a very interesting slide which gives us a complete picture of biochemical markers, and not to miss the severe inflammatory markers, increase in ferritin, CRP, and interleukins. Again, this is a very interesting slide because it typically shows the laboratory changes in patients with severe and fatal COVID. Now, as I mentioned that the COVID-19 infection can vary from mild, asymptomatic to severe cases. Now, inflammatory markers typically rise in severe disease. The CRP, ferritin, procalcitonin, interleukin, especially interleukin 2R, 6, 8, and 10 are the markers which raise in severe or fatal disease. Also, the cardiac markers, the myoglobin, CKMB, and cardiotropinins. Now, a very interesting and the largest study so far, I've picked some studies from the literature. The meta-analysis study, in this comprehensive meta-analysis, this was conducted by Henry et al., where he picked up 90 articles. In the study, 74 articles were excluded, but 21 studies were included, which gathered 3,377 patients and 33 lab parameters were studied. And studies compared patients with severe and non-severe COVID-19 patients. Patients with severe and fatal disease had significantly increased WBC's count, decreased lymphocytes and platelet counts compared to non-severe disease and survivors. Also, biomarkers of inflammation, cardiac and muscle injury, liver injury, kidney function and coagulation markers were significantly elevated in patients with both severe and fatal COVID-19. Interleukins, especially 6 and 10, serum ferritin, were strong discriminators for severe disease for survivors and non-survivors. This meta-analysis enabled significant risk stratification between patients with or without severe disease based upon lab findings. Now, role of cardiobiomarkers in severe COVID-19 becomes very significant. Biomarkers of cardiac and muscle injury are significantly increased in severe and fatal COVID-19. Patients who died had significantly raised cardiac troponins, suggesting viral myocarditis and cardiac injury. Another term which is well heard of is multi-organ failure. Severe COVID-19, in severe disease, there is progression towards multiple organ failure and all the organs getting infected, especially the renal and liver failure. There is significant elevations in liver enzymes, the AST and ALT and renal biomarkers, BUN, and serum creatinine and other coagulation markers. Now, something interesting, and I also saw questions coming up of cytokine and storm, and I hope these are well answered as we go through the slide. Emerging data suggests that many patients infected with COVID-19 may die due to an excessive response of their immune system, characterized by abnormal release of circulating cytokines. This is termed as cytokine release syndrome. Cytokine release syndrome plays a major role in deterioration of COVID-19 patients, from pneumonia to acute respiratory distress syndrome, systemic inflammation, and ultimately multi-system organ failure. This phenomena of a plethora of cytokines wreaking havoc throughout the body is termed as cytokine storm. So basically, these are patients where there is excessive response of their immune system. And these cytokines play a crucial role. The interleukin 6, 1, 2, 10, TNF alpha, and TNF and interferon gamma. And especially the increased levels of interleukin 6 in serum have been correlated with adverse clinical outcomes. Therefore, measuring interleukin 6 is very important. This classifies interleukin 6 as a potential target for COVID-19 targeted therapy. Interleukin 6 and IL-6R antagonists are underway for clinical trials for the management of COVID-19 patients with severe respiratory complications. Now, Worldometer is measuring COVID-19 every day. This is the data I picked up today. Worldwide corona cases are increasing, and you are seeing in news also. This is the latest data as on date for India and worldwide. Our hospital was designated on May 16th of this month for COVID-19. As on today, we have 49 cases and 3 deaths have occurred, 5 deaths. At our hospital, we follow all safety protocols. We have a separate wing managing COVID-19 patients. Thermal screening is done for everyone entering the hospital. Wearing mask is compulsory. At the moment, I'm sitting in my room in the hospital. Therefore, I'm not wearing a mask. I'm alone. We have a dedicated flu screening clinic. Every equipment is disinfected after every use. There is sanitization of all areas multiple times a day, and hand sanitizers are freely available at all touch points. So we have a designated isolation ward for COVID positive patients. 50 beds, and more severe cases are shifted in designated COVID ICU. And these deaths which occurred, most of the patients had developed complications. They were on ventilator with ARDS, and one of them had massive pulmonary embolism. Interesting to note is that 11 cases came from the same family from Aligarh district in Uttar Pradesh, and they had very mild symptoms, only fever with sore throat. 2 of them had diarrhea, and all of them tested COVID positive. The lab investigations were all normal, except the liver enzymes AST, ALT were only mildly raised, and CRP was positive. I'll talk about a few examples of cases just to have an idea how they presented to us. The first case which presented, also made to the newspaper, was a healthcare worker. Now, this lady was, just exchanged some medicines. Don't know from where she picked, And she was a 50-year female, no history of comorbidities, and presented with loose stools. 3 to 5 loose stools per day, with nausea and decreased oral intake, intermittent abdominal crampy pain at the time of defecation, took Norflox TZ at home, but wasn't relieved. So she got admitted on 22nd of April and started on antibiotics and, had one fever spike. Her lab investigations only showed mildly elevated liver enzymes. Ultrasound had some liver, had hepatomegaly with gallbladder, some multiple stones. CBC had leukopenia, and PCR was positive. At that time, our hospital was not designated, so she was referred to a designated COVID hospital and Safdarjung hospital, where she was quarantined for 14 days. Another case came to our hospital for a checkup because this patient had chronic kidney disease, cardiomyopathy, and coronary artery disease, but was presented to our hospital for complaints of shortness of breath for 2 days. The BNP was raised, and tropi was raised, urea, creatinine, and uric acid was raised, calcium was low, total protein was 5.4, albumin was 3, and again the BNP and tropi were repeated and were raised. Cardiology consultation was taken and advice followed. In view of increasing creatinine 4.2, dialysis was done again. In view of COVID-19 pandemic, swabs were taken, and since they were positive, the patient was shifted to isolation ward, and again, the patient was referred because it was on 1st of May, and at that time our hospital wasn't designated as the COVID hospital. So the patient was sent to Loknaik hospital, where the patient was again further referred to a home quarantine for 14 days, and referred again to another adjunct hospital. Another case presented to our hospital, this was a typical diagnosis of COVID-19 case, who presented to our hospital, 60-year male, who presented with low-grade fever, chills for the 6 days, shortness of breath, sore throat, and was admitted in COVID isolation ICU, and was put on bronchodilators and azithromycin antibiotics and supportive treatment for tachypnea and worsening hypoxia. He was advised mechanical ventilation, but the patient attendants refused, even after explaining poor prognosis. His urea and creatinine levels were increasing and worsening, and he suddenly developed hypertension and bradycardia. CPR was started as per ACLS protocol, but even after best efforts, this patient could not be revived, and he was declared dead on 21st of May. And D-dimer and ferritin levels were raised along with urea and creatinine. So these are the lab investigations for this case. So what we just want to share, that labs do play an important role, and there is a need of increased number of labs in view of the increasing COVID, and the critical labs role comes from WHO, ICMR, and other national and international scientific organizations in patients monitoring and surveillance, and few of the references. And to summarize, these unfortunate international pandemics, such as the current one, give us a pivotal role in the care of those affected by the virus, and the role extends beyond the diagnostic and clinical needs. It should be comprehensive and to meet the needs of the medical community, and the police, which is there, and more or less it lies on us as citizens. Every ordinary man, we all have to fight together to defeat this corona infection, to have the victory over it, and definitely we can. Together, this is my lab, biochemistry section department, and we maintain social distancing in the lab also. In the end, I would like to thank our president, our medical director, Dr. Mani, who's very encouraging, inspiring, our lab director, Dr. Neelam Khanna, who's very caring and keeps guiding us. She is also the infection control of, head of our hospital, Dr. Jatinder Bhatia, again, for giving me this opportunity to connect with all of you. My colleague, Dr. Piyush Dikshit, helping me with this presentation, and all my colleagues helps my lab staff. My family, friends, and I would like to share, I practice Nichiren's Daishin's Buddhism, where Buddha said that we all are, born to be happy, and this world is born to be happy, and above all, God Almighty, who will help us through this pandemic. Thank you, everyone, and I'll be happy to answer any questions if I'm able to. Thank you.
Thank you so much, Dr. Reema. It was a beautiful presentation. And I think all the queries which were there, you have tried to remove. Still, there are questions which we will take in the end. And now I request Dr. Rupali Suryawanshi to please start with her presentation.
Good afternoon, all of you. Myself, I'm Dr. Rupali Suryawanshi. I am a consultant microbiologist at Ruby Hall Clinic, Pune, Maharashtra. Ruby Hospital is a well-known NABH accredited hospital. We have an NABL accredited lab since a long time, and since this pandemic of COVID is there, we are in the testing both by the RT-PCR and gene expert, by gene expert method, almost since last 2 months. So it's a huge task, and all of us are sailing in this boat where this pandemic is really growing up, and hopefully we will be coming out of this. Now, my role today is to make you aware about the various microbiological aspects for the diagnosis of COVID-19. I'll be sharing the various tests which are pertinent to microbiology. So, yeah, role of laboratory. Now, my two speakers, the initial two speakers have already covered this, but still, this is like enters human body, there is an infection. After this infection, there is a formation of the disease, recovery, and in some unfortunate cases, the death occurs. The various lab tests which are available, depending upon which stage the patient presents to us, we have to choose the correct test related to that stage of the patient. For example, if the patient is in the stage of infection, we need to diagnose the case. Whenever he is presenting, whenever he is in the stage of overt disease, where already the disease has progressed, we need the test which will help us in the staging, prognosis, therapeutic monitoring, and after recovery, what we need is the epidemiological surveillance. Now, today I'll be talking about the microbiological test, which will fit in all these different categories. So at the end of my presentation, we will again come back to the slide and see which test can be useful. I'll be sharing my knowledge on 3 different tests which are pertinent to microbiology: nucleic acid amplification, that is a PCR, serology, detection of antibodies, and antigen detection. So let's see one by one. So first is the nucleic acid amplification test. So real-time reverse transcriptase polymerase reaction, that is RT-PCR, is current gold standard method for diagnosis of infection, the COVID-19 infection. The various molecules, a lot of tests, a lot of kits are in the market approved by ICMR, which are targeting mainly 4 to 5 different types of antigens, or the viral genes rather. They are the nucleocapsid, the envelope, spike, RNA-dependent RNA polymerase, that is RDRP, and ORF1. So whatever kits we are using are currently targeting all these different types of viral genes. And with the experience, this has been classified as first line screening, EG, confirmatory screening, confirmatory RDRP, and again additional confirmatory screening, NG. So the kids have the combination of all these genes. The kids, they target these genes, and most important is the confirmatory one, which is the RDRP gene. Now, when we talk of testing, the first and the very common question which comes in the mind of everyone is whom to test. Lot of debate is going on. Everyone is confused to whom we should test, but we should always adhere to the latest ICMR guidelines. Now, what latest ICMR guidelines say? These are the different categories of the patients. When in clinical practice, you're suspecting any patients, you're seeing any patient which will fit in this categories, they should be advised the corona testing by RT-PCR method. So what are these? So first is all asymptomatic influenza-like patients who has a history of international travel in last 14 days, all symptomatic influenza-like contacts of laboratory confirmed cases, all symptomatic healthcare workers or frontline workers which are involved in the management of this COVID-19 patients, all patients of SARI, that is severe acute respiratory infection, asymptomatic direct and high-risk contacts of the confirmed case. They should be tested once between day 5 and day 10 after coming in contact with that patient. All symptomatic influenza-like illness patients coming from the hotspot or containment zones, all hospitalized patients who develop influenza-like illness, all the symptomatic influenza-like workers of the influenza-like among the returnees or migrants within 7 days of illness. So when we say about influenza-like illness, what does it mean? ICMR has defined that you have to call any illness as influenza-like illness. It's an acute respiratory illness with fever of more than or equal to 38 degrees Celsius and cough. And SARI is again an acute respiratory infection with fever of more than 38, cough, and patients requiring hospitalization. So these are basically broad categories as per the latest guidelines by ICMR, whom we should be tested, whom the sample should be sent for testing by the RT-PCR method. Now, once a lot of hospitals have been working, it is the threat in the mind of surgeons whether we should wait for the test or we should go for the operation of the patient. ICMR has clearly said that no emergency procedure should be delayed because of lack of tests. However, if you're suspecting that your patient falls in any of the categories which we have just seen, the sample should be sent simultaneously and you have to carry the procedure considering that patient as potential patient suffering from COVID and take all the necessary PPEs or necessary precautions which will be required for to prevent the healthcare workers not getting infected. So whatever categories I am again emphasizing, all these categories are only meant for RT-PCR test and it is not for the other test. Now, when we talk of RT-PCR test, what are the samples we should send to the laboratory for the diagnosis of this COVID-19 infection? Now, these samples can be broadly classified as upper respiratory tract samples and lower respiratory tract samples. Upper respiratory tract samples include nasopharyngeal swab, oropharyngeal swab, nasal aspirates. Lower respiratory tract specimens include sputum, bronchial washing, BAL, TT secretion, ETT, lung biopsy. So basically, depending upon the stage of the patient and what a sample easily can be collected by the healthcare worker. Now, one should remember that for all the microbiology investigations, whether it is culture or it is PCR, a good sample will give you the good result. So the quality of the result is directly proportional to the quality of the sample one is taking from the patient. So appropriate collection of the sample is very important. There are the CDC and even ICMR has given the guidelines how to collect nasopharyngeal swab, oropharyngeal swab. So that should be collected. Now that should be collected properly. When you're collecting these samples, it is required that you have to collect them in a Dacron and a nylon swab and put it in the viral transport medium. Because these are viruses, they are not bacteria. They may die if you don't put the viruses in the viral transport medium. So before you are suspecting any patient, it is important you have to procure the swabs and viral transport medium from your microbiology lab or the lab where you are sending these samples. All the lower respiratory tract samples like sputum, bowel, etc., they can be collected and sent in a sterile container the way you're doing for other microbiology investigations. Now, transport is also very important because these are viruses, they may die. So once you collect these samples, they should be transported as early as possible to the concerned laboratory. During the transport, it should be refrigerated. So you have to transport them in an ice pack if the lab is close by. Now you can send, but it may not be possible that that all the hospitals have this facility of testing. So if you're sending the samples outside to the testing facility, and if you're suspecting that the transport time is up to 5 days, the storage conditions can be just simple refrigeration up to 4 days, that is 4 degrees Celsius. But if you're suspecting that the samples will take more than 5 days to reach the concerned lab, then the sample should be stored at -70 degrees Celsius. So all this appropriate sample collection, transport, storage, this will affect the result of the PCR. So all these factors should be kept in mind when you are collecting the sample. Now, being a microbiologist, I cannot go without saying about the infection control practices. So it's very important that only a trained healthcare worker with full PPE should collect the sample. When the person is, the healthcare worker or the doctor is collecting the sample, you have to restrict the entry of other attendees when you're collecting the sample so that there is no cross-infection to the others. Specimens should be collected as soon as possible once you suspect the case, regardless of the time of onset of the symptoms, and then maybe you can store it appropriately and then you can send the samples to the lab. It is recommended to test multiple clinical samples. So you can have the both upper and lower respiratory tract together samples you can send, but it may not be feasible at all the time. So even one good sample is sufficient for the PCR testing. You have to transport the specimen as early as possible, and remember you have to transport the specimen in triple packing system because these are the biohazardous samples, and that may lead to infection to the person who is transporting this infection. Even the transport person should wear appropriate PPE when he is transporting this specimens. Now we assume that the sample has reached the molecular lab. Now, when we talk of only sample collection and the infection control practices required for they are required for the sample collection, equally important inside the molecular lab also, because these are potentially hazardous samples and we don't want our technicians, the laboratory staff, the microbiologists, or the doctors to get infected. So there are some norms everyone has to follow when you're working in the molecular lab, the PCR lab. Before starting and at the end of the work, every person working in the molecular lab should wear appropriate PPE as per the risk involved. So the molecular lab will have a receptionist, the person who will be accessing the samples, the actual technicians who will be doing the sample decontamination, RNA extraction, the doctors. So you have to lay down the form the policy where appropriate PPE should be used as per the risk involved by that person. Workflow should always be unidirectional. Now, all of you know PCR setup is totally different. There are different rooms, the reagent preparation room, this specimen extraction, RNA extraction room, pre-PCR, PCR, post-PCR room. So whenever you're processing the sample, the workflow should always be unidirectional. This is good for the healthcare worker also and that sample also, so that there are no chances of cross-contamination. Always use dedicated supplies and equipments in separate rooms, and do not shift those supplies, maybe these the pipette tips or the small centrifuge and everything from one room to another room. Do not open reaction tubes post amplification to avoid cross contamination. Procedures which lead to aerosol generation like vortex or centrifuge, that should be strictly done inside the biosafety cabinet or the laminar flow. Always change pipette tips between the liquid transfers, and most important, disinfect all the workplaces thoroughly after every procedures. So if you're working in a biosafety cabinet or laminar flow and you have finished the RNA extraction procedure, don't wait for your subordinate staff or the class 4 worker to come and clean. It should be the habit of even that person sitting there to clean the surface then and there itself, and later a thorough disinfection can be carried out. Now, after we have prepared the sample, the most important question comes is which PCR kits should be used. Now, all we have to remember is we have to use all ICMR approved or ICMR validated RT-PCR kits only for the diagnosis of this COVID-19 infection. If you go to ICMR site, there is a whole list of the PCR kits which has been validated by ICMR. Just pick up those kits, validate those kits with the known positive and negative sample. If you're sure that the kit is giving good performance related to your thermal cycler you're using, you can go ahead with that kit. Now, the sample has come. We've seen how we have to be careful so that the person should not get infected. We've chosen the kit. Now we are imagining that the whole thing is done. The PCR is done, and now the most crucial part comes, which is the interpretation of the PCR. Now here in the PCR is a polymerase chain reaction where because of the amplification and the 3 different steps of PCR, the multiple copies of the virus will be generated. Now, when we interpret this PCR reaction, we interpret them in terms of something which is called as CT value, that is the cycle threshold. So this cycle threshold is nothing but number of replication cycles which are required to produce a fluorescent signal. So that is when the virus multiplication occurs, there are various cycles. So it is the minimum level of these cycles which will be required to produce visible fluorescent signal so that the machine can pick up and he can give us the CT value. Not to say lower CT value will represent obviously higher viral RNA load which is present in that sample. Usually CT values less than 40 are usually reported as PCR positive, but every kit gives its validation protocol and its interpretation criteria. So we have to stick to the kit literature of what kit we are using. Now PCR, the question comes when this PCR test is usually positive. Now the data shows that PCR can come positive as low as day 0 of these symptoms. So, and it can remain positive up to 3 weeks post-infection. And after 3 weeks, slowly this PCR positivity goes on decreasing. Now it's our observation that the CT values in severely hospitalized patients are usually lower than the CT values of mild cases. PCR positivity may persist beyond 3 weeks in the severely ill patients as compared to mild cases. So mild cases, previously the ICMR has changed the guidelines now that there is no need of the repeat testing. Once you are diagnosed, the earlier protocol was when you diagnose any patient as COVID positive, you have to admit the patient and then he will be hospitalized for 14 days. And after 14 days, we have to do the test. And then again after 24 hours, that is 14th and 15th day, we have to do the test. And if the PCR test is negative, then the patient can be discharged and advised home quarantine for 14 days. Now this policy is not there. There is no, the retesting policy is being taken out. But for the interest, if you see, most of the severely ill patients, they remain positive for more than 3 weeks. And as it is for the other PCR methods, one should remember that when the PCR is positive, it doesn't mean that the viable virus is positive. PCR do not differentiate between the dead and the live virus. So in such a cases, what it is detecting is just the viral RNA particles. But that doesn't mean that the patient is still infective or still the viable virus is there. So when we are interpreting such positive results at very late stage of the disease, one should be very cautious. Even the reporting doctor, microbiologist, and the clinician who is interpreting these results they should understand that each and every lab diagnostic test has its own limitations. So that should be taken care of. There are some studies who have shown that this viral RNA can be positive. This PCR test can be positive even beyond 6 weeks. Now, even beyond 6 weeks, one should look for the probable reasons like a testing error, whether it is a reinfection or it is reactivation. So still after 2 months of this pandemic, we are still evolving lot obviously behaving, and one day we will get the answer. So this is what I was talking about, that when the PCR can come positive, as you can see, as low as day 0 from the infection, the symptoms appear to about 2 to 3 weeks, we can get the RT-PCR test as positive. So obviously samples which are collected Below this, that is before the symptoms and after 2 to 3 weeks, the chances of getting false negatives are very, there are obviously chances of getting false negatives. Now, when we interpret any test, the molecular test, obviously each and every one comes with the chances of, the interpretation comes with the chances of false negatives and false positives. So one should be very aware, the clinician should be more aware that if you are reporting any test as PCR negative, it is not 100% foolproof, and if he is strongly suspecting, we have to look into the factors which has led to this test as negative, and maybe retesting can be advised. So what are these factors which has led this test become negative, that is the false negative? I have categorized them into two different ways, the pre-analytic factors and analytic factors. So the pre-analytic factors include inadequate sample collection, transport, handling, and storage, which I have already emphasized you all. Specimens which are collected too early or too late, that means the viral load is not that the kit is able to pick up. So this factors can be divided as pre-analytic and the post-analytic. The sample collection, transport, the time of collection of the sample, the presence of inhibitory substances, manual pipetting errors, sample contamination, the starting antivirals prior to the testing, and occurrence of viral genetic mutations. So these are the factors, that is before testing, these are the factors which can lead to the false negative result of the PCR. Now, what are the analytic factors? That means that where the test can go wrong. Testing outside diagnostic window, use of non-adequately validated assays, lack of harmonization of the probes and primers, instrument malfunctioning, non-specific PCR annealing, and misinterpretation of the expression profiles. So these factors should always be should be kept in mind before you will release any PCR negative result. Now, sometimes, very, very occasionally, we see false positive also. That is not our experience. We haven't seen this, but this is what literature says, that occasionally you may get false positive because of the technical errors and reagent contamination. So if the you have to be really cautious about this also. Now, the next interesting thing is pooling of the samples. Now, as the pandemic is growing up, the labs are getting flooded with these samples, and it is becoming very difficult for the labs also to be in tune with the amount of the samples, the pressure of reporting the result within 24 hours. We don't have, all the hospitals don't have a very good the molecular setup. Even if the molecular setup is there, only 2 trained technicians, 2 or maximum 4 trained technicians are there. So we should cope up with this workload which is increasing. So this idea of pooling of samples came, and then ICMR has released the guidelines. Then we can pool these samples. Now these guidelines, these are guidelines given by ICMR, and this is pooling. This shows the pooling of samples only for the PCR test, and it is not for the antigen or antibody detection. So what ICMR says, you can pool these samples if the samples are coming from the area who has very low positivity of up to 2%. So if the samples are coming from the area with the positivity of 2%, you can pool sample. Pooling of the sample is not at all recommended if the positivity in that area is more than 5%. And if the area is having positivity of 2 to 5%, sample pooling can be considered only for community survey or surveillance. So otherwise, the sample pooling is not allowed or not acceptable for diagnosis of the individuals. And when the pooling has to be done, the preferable number of the samples to pool is usually 5. So basically what you have to do is, if the area has less than 2% positivity, 5 samples can be tested together. There is a whole different procedure how the PCR can be carried out from that 5 samples. If the pooled PCR comes negative, all the 5 results are given negative. But if the pooled PCR comes positive, you have to individually test those 5 samples, find out the correct positive, correct negative, and then only release the result. So that was about the pooling of the samples. Now coming to the end of the PCR reactions, it is very important that looking at the nature of the transmission of this virus, the aerosol and the droplet, it is very important to protect the laboratory persons also. So the laboratory safety guidelines has to be strictly followed, because we don't want any of our laboratory technicians or the healthcare worker or the doctors, residents, any one of us to get affected by this corona, the occupation hazard of this corona. So all the time, strict adherence should be given to donning and doffing of the PPE. Correct method of wearing and the donning and doffing of the PPE should be carried out. You should never touch the PPE. The adequate and correct hand washing should be carried out at each and every step. Appropriate sample storage as recommended by ICMR. Appropriate disposal of the samples as per local and national biomedical waste guidelines should be followed at all the times, so that there is no cross infection to others. Coming to the next part of my talk, that is serology, detection of the antibodies. Now, when we see of the PCR reactions, it requires a separate molecular setup, trained technicians, trained lab doctors, trained microbiologists. Now, as compared to serology, which is detection of antibodies, most of the labs are doing this antibody test. They are well versed with the reading of ELISAs and rapid methods, and we are really waiting when the day will come that we will be doing the antibody test. So much debate is going on, but till today, none of the serological methods are being allowed by CDC or any health organization for diagnosis. Even our ICMR has always emphasized that confirmatory test for COVID-19 diagnosis is till date is only RT-PCR, and this antibody test has to be used only as a surveillance purpose, and it should not be used as a sole method for the diagnosis. Now, which are the various kits which has been available in the market and approved or validated by ICMR are of two types: the rapid antibody CAR test and ELISA test. Now, when any virus infects the human body, the protecting antibody is called as a neutralizing antibodies. And the presence of this neutralizing antibody is confirmed only by plaque reduction neutralization test, which is not an easy test to do in the day-to-day in the laboratory. So we really don't know that when we will be starting using ELISA, how it is going to actually help us. But still, we are hoping for best. Now, this is the picture of the immunology, how the virus immunologically, what immunological changes happens in us when the virus enters human body. So as you can see at the week 1, what we see are all the antigens, the virus RNA, which can be detected by the PCR, the nasopharyngeal PCR or ball or whatever sample. Now, as we see, when the antibodies are starting, both the IgM and IgM antibodies are starting almost at second week. So even when we want to use this antibody in future for diagnosis, it will be after this period of 1 to 2 weeks and not before that. So we have to remember that the antibodies will take its own mean time to come in the blood to form the detectable levels of antibody, and then only they can be used. So what are the advantages of the serological test? It is an indirect way to diagnose and to see also that how is the host immune response. It can be an important for the patients with mild to moderate illness who has presented very late, maybe more than 2 weeks, and now RT-PCR may not come positive, but the patient, we are still suspecting the patient, so we can use antibody for the diagnosis. It is an important tool to understand the extent of COVID-19 in the community, so that for the surveillance we can see how much the disease has spread and how much herd immunity we have got, to identify the individuals who are immune and potentially protected, basically the herd immunity. So these are the advantages which when we will be using the serological test. Now, what are the disadvantages? We will be detecting the infection late in the course of illness, that is more than 1 week. These antibodies may cross-react with other seasonal coronaviruses, so that should be kept in mind. Rate and kinetics of serological response has not been clearly defined so far. The long-term persistence and duration of protection by these neutralizing antibodies remains unknown. So still, it is an area of research that how we are going to use these antibodies in future. How to choose the antibodies? Antibody test in your setup. Now, all the IgM, IgG and total antibody ELISAs are recommended by ICMR, and it is approved by ICMR. Most of them have the good specificity of more than 95%. Now, when we want to use any serological reaction, the basic funda of the serology, testing the paired serum sample, applies here also. So you have to always rely on paired serum samples. So you have to test initial testing with the initial PCR, and then again repeat test after 2 weeks to see rise or fall of the antibodies. That will give most correct diagnostic value to the serological test. Now, when we see which type of different antibodies this virus is producing in our body, two most important antibodies what we see is the antibody against this antigen, which is called as NC. Now, this NC, the antibodies against this NC are found most abundant. So, they are the largest antibody which is found in human blood after the infection. And there is one more antibody, which is the antibody against this receptor binding domain S, that is RBDS. Now, this RBDS is the host attachment protein. So, these two types of antibodies are usually seen in human blood. Because the NC antibody is the majority of the antibody, if we will select the ELISA, which will detect this NC antibody, this will increase the sensitivity of the test. If we choose the antibody, if we choose ELISA, who are detecting antibody against these RBDS, the specificity of the test will increase. So whenever you want to choose any ELISA test in future for your lab, you have to see that at least these two antigens are covered. So this good sensitivity and specificity will be achieved. Now coming to the antigen testing. So the third part of my lecture is the antigen testing. The antigen testing is the detection of the antigen in the same specimens which we are using for the molecular test. That is the upper respiratory tract and the lower respiratory tract. Now antigen testing, they are simple tests. They can give the result instantly. So that they can be used as a point of care test. They have good specificity, but they do not have good sensitivity. So even if they have an advantage that they will give quicker result in 10 to 15 minutes, and of course the cost will be very lesser than the molecular assay. Molecular itself require the infrastructure, trained staff and everything. So that cost totally comes down. But the negative results, we have to still confirm those negative results with the nucleic acid test, with the PCR methods. Until now, only one antigen assay has been approved by FDA. So we are still in the stage of finding more of antigen assays and their actual values, the advantage, the sensitivity and specificity of this test. So hopefully in future we will get good such antigen testing methods. So again, coming back to my original slide, the first slide, that after the SARS infects, there is an infection, overdoses and recovery and sometimes death, how this virus is behaving inside the human body. So during the stage of infection, we want to diagnose the patient, and for diagnosis, what is recommended is the RT-PCR test. Now, in the when the patient is already in the stage of overt disease, we want to stage the disease. We want to find out the prognosis and therapeutic monitoring. For that, we have to use various IVD approved tests and other various tests which has been covered by the other two speakers. The hematological and biochemical monitoring test can be used. And after the patient is recovered, and in general in the population, what we want to see is the epidemiological surveillance. And for that, what we have to use are the antibodies. So the crux of my lecture is, when you want to diagnose the coronavirus infection, RT-PCR is the gold standard. Antibodies, even if it is very fascinating to to start antibody testing, it is only for the epidemiological surveillance. So coming to the end of my talk, what I would like to say is the knowledge of this diagnostic test for the SARS-CoV-2 is still evolving, and the clear understanding of the nature of the test and the interpretation of the finding is important. We are still finding new things, and we have to depend on a lot of things. So thank you so much for the patient hearing, and thank you so much 360 Health whole team, Dr. Bhatia, giving me this opportunity to share my little knowledge on the microbiological aspects. Thank you so much.
Thank you so much, Dr. Rupali. I think it was a beautiful talk. And I must compliment all the faculty, because there are a lot of messages that all the presentations were very good. So that's, I think, the whole webinar was highly informative because a lot of people really want to know, what is the status, where are we, what is going to happen tomorrow, because there is no history attached to it, and lot of questions are unanswered, and every day things are changing. So our knowledge also from various sources, every day we read something different, and people get confused, what is right, what is wrong. So thank you so much, and we'll just take a few questions. The first question is by Dr. Sandhya, and this is, I think Mamta can take it, that why few patients go into cytokine storm and why others don't go. Any reason for that? Anyone of you can take this.
Am I audible?
Little low voice.
I think the patient with comorbidities actually are the ones who are entering more into cytokine storm. So that is all. I really don't have an elaborate answer to this, that why some are entering, because I mean, this is what the hypothesis is going around for COVID-19 infection. How, when, and which way the patient is going to behave, no one knows. Today they are doing fine, and next day they end up, dying. So no idea. Anybody else has? But I feel that it's the comorbid conditions which is kind of a predisposition to cytokine storm.
I think I can add to this.
Yeah, Dima.
What I read from the study and literature about cytokine storm is that typically, a cytokine storm is about. Am I audible?
Yes, Rima.
So cytokine storm is all about the immune response to the infection. Coronavirus is a viral infection, and the body responds to it. There is an immune response. So where there is where it's all about immunity. So when the immune system is weak and there is a strong immune response, there the whole 2 minutes. So there when the immune response is very strong and in a severe, cytokine storm is a severe form of COVID-19 infection. So in severe cases, what happens is where there is severe response of immune system, the inflammatory markers and the interleukins, they react. And in that case, there is multi-system organ infection. And that is when the body lands into the cytokine storm. There is a plethora of reactions which I shared. So that is what is happening.
I think why it happens in a few patients and why not, there was some hypothesis which I remember was circulating that the flu vaccines have got something to do with it. Although most of the hypotheses, they are there and then they are refuted in a week or so. So this one also has been refuted. But people say that if the body has already been primed to those vaccines, then the reaction, the immunological response to it would be more severe, and that is how the patient selection is happening. That it is happening in a few and not happening in all. So that is one. But then again, as most of our knowledge on coronavirus is, this is also hypothetical and evolving.
Can I
Very
add,
Dr. Mamta,
Dr.
it is
Bhatia?
also being seen.
Yes, I can hear somebody wants to add on to it.
Dr. Munshi here.
Comorbidities are also
Yes,
a cause
Dr.
of in comorbidity conditions. Also, the infection is more severe, and these cases are also causing more deaths.
Dr. Neeta Munshi,
Yeah.
yeah,
Yes.
Dr. Munshi,
Yes,
you
Dr.
want to add something?
Yeah, hi. I just wanted to add to this that along with immunity, there is something called stress on the body. And whenever the body goes through stress, for example, post-operative period is when the body is going through stress and we become immunocompromised. So whenever we are immunocompromised, along with stress on the body, the cytokine storm hits. And that's where, so in some people, we get a cytokine storm when there is stressful condition along with comorbidities. That's what we have seen. So I just thought I'll add that. Thank you.
Thank you so much.
Thank you, Dr.
Thank you. Thanks. I think lots of discussions are required, and as all of you have discussed, that hypotheses keep changing and things are evolving. So I think we'll keep updating our knowledge. And the next question is, what is the most specific test to diagnose cytokine storm? I think it was discussed also, but we can take it again. Yes.
I think Dr. Reema would like to take it. I
Yeah,
think it is
Reema?
Yeah. So inflammatory markers, the biochemical inflammatory markers are the most characteristic markers for a cytokine storm. The various interleukin 6 or 2, 6, 8, 10, and especially the interleukin 6 has been the most promising marker for cytokine storm. And also, therefore, the targeted, it's one of the targeted therapy. I discussed with one of our clinicians who was, trying to find out the cost for the drug. And, he inquired and he shared with me the cost of the drug was 48,000. Of course, they couldn't, the patient could afford, he just that day had a discussion with him. So these are also under clinical trials, these kind of drugs. So interleukin 6 and 10 are coming up as the inflammatory markers.
Question related to the previous question. Will interleukin 6 and interleukin 10 ratio would be useful for predicting the cytokine storm? I mean, the ratio of IL-6 and IL-10, can it be useful for predicting the cytokine storm?
I'm not able to answer this question right away, but maybe I will have to check and I can get back on email or something. Is that okay?
Okay, Dr. Harsha asked this question. We'll get back to you, Dr. Harsha. Yes. So another question is there any effect on the hemoglobin?
No, not really. Not any specific. I mean, it just depends upon the clinical condition of the patient. It's not like, I mean, we have not seen that hemoglobin dropping. It is just a reflection of the progression of the disease and the presenting condition of the patient. I mean, of course, if he's going into DIC, if he's going into hemolysis, the hemoglobin is dropping down. But as such, we have not seen that, hemoglobin is affected by the pathogenesis of the virus per se.
Right, thank you. There's another question that at what count of platelet should LMW heparin be started?
Actually, it's not like that. It's like, less than 25,000, one must not start a prophylactic LMWH. Also, if the patient is bleeding. So the platelet count becomes of importance of, why it is important to know the platelet count is that if it is less than 25,000, prophylactic LMWH should not be started. If it is more than 25, then only it is indicated. So that's what I told. It's not, there's no cutoff for it to start, but there is a cutoff for it not to start.
All right. Thanks. There's another question for Dr. Rupali that if viral transport media is not there, is there any alternative to it?
No, there is no alternative to viral transport medium. You have to get ready and procure from the nearest lab where you are sending the samples, or any good company, High Media or some similar companies you have to buy, but there is no alternative to viral transport.
Okay. Two more questions we'll take. One is that can we do OT swab testing to find out, to ensure the sterility of OT for COVID testing?
How we will do that? Does this question was for after the OT of when we do the operation of the positive patients, or I mean, I didn't get the question.
I think what I understand is probably she wants to ask that after a surgery or when the OT is exposed to a COVID positive patient, post that, is there any way that we take a OT swab like we do for bacteriology, that we take OT swab, do it, testing for PCR and then find out, if infection is still there or not.
Yeah, no. Till now it has not been recommended, and there are clear guidelines by ICMR when we have to operate on. We are operating, most of the hospital, the government and all hospitals are operating COVID positive patients if they require the surgery. So there are guidelines how to clean the OT, what should be the OT structure, and then we have to give emphasis on thorough disinfection after the OT. That is what is most important, with the correct percentage of sodium hypochlorite as mentioned in the guidelines.
Right. So that means sterilizing after a COVID patient surgery is more important.
Yes.
All right. So what is the role of gene expert And what is the turnaround time of RT-PCR COVID in GeneXpert? And can we use it for diagnosis? Yes.
Of course, you can use GeneXpert. GeneXpert, see what I had talked as the RT-PCR. So these PCR reactions can be done in the open system and closed system. The conventional ones where we require the fancy molecular setup is for the RT-PCR, the open systems of the RT-PCR where we require thermal cyclone and different rooms are there. GeneXpert is one of the closed system and it also uses the same principle of RT-PCR, but everything is happening inside that single cartridge. So it is very, very user friendly. It releases less aerosol generation, so that the lab technician who is working is safer than the other reactions of the RNA extraction and everything. The TAT of GeneXpert is superb. We are doing both by the RT-PCR method and GeneXpert. The cycle takes only 45 minutes. And it is very simple procedure. You have to just take some microliter, put it in the cartridge, and the cartridge is loaded in the machine, and the result is available within 45 minutes. Now the lab has to be enabled accredited for the GeneXpert. One of the viral, maybe HSV, H1N has to be in the enabled accredited scope, accreditation scope. Then only you can go about the COVID testing on GeneXpert. So yes, GeneXpert can be used, and it is very good system, and it has a TAT of only 1 hour if it is in the same hospital.
Yeah.
And if I can add, Rupali, for batch testing, I mean, if the sample volume is higher, I think RT-PCR comes out to be more cost effective than
Yes.
the CBNAT.
Yes, cost effective is RT-PCR is more costly because this cartridges and everything, they are quite costly, GeneXpert.
Yeah, so if you have fewer number of samples, then maybe CBNAT, and if higher volumes, then maybe RT-PCR, right?
Yeah, we actually most of the load is on the RT-PCR, and then if the patient comes in the labor and there is some emergency, because the PCR we are doing it by batches. We are already the samples are there, and we have decided at 9 o'clock we are running those 40 to 50 samples, and then that is going to take another at least 5 to 6 hours. And in between, if some surgery has to be the surgery is there, or and the patient is suspected, if any person comes, a lady comes in labor, at that time we are using GeneXpert.
Dr. Rupali, how many number of samples would be there for being it viable, the GeneXpert? Because we are also planning to start soon.
I did not get your question, ma'am. Will you please repeat the question?
How many number of samples should be there for making it cost effective, GeneXpert?
Okay, cost effective GeneXpert. I think the CFIT guy should give you good deal so that it will.
No, we already have it. We already have it.
Just 1 second, Reema. What happens in GeneXpert? It is a single cartridge-based test, so it is cost per test, which is important. Whereas in RT-PCR by other methods, you have to run standards and calibrators and all that stuff. So the cost varies, with the load. But here, load doesn't matter because it's a single individual cartridge-based test. So how you can negotiate for that cost, that matters.
But there is a cap put here by the government. So we can't increase the
whether it is
that is not the patient, but for you negotiating with vendor, there is nothing like that. Yeah. And rather, there is another similar machine by Mall Bio, which is a small machine, which has also been approved by SCMR recently. Earlier, they were saying that it can be kept only in the labs which are doing PCR and are approved for PCR for screening. But now they are saying that individually also, if somebody wants to do it, it has been approved. So for those labs where load is very less, these machines are very useful.
Currently, we have.
So there are many questions. Yeah. So there are many questions still, but I think we've already spent 1 hour, 45 minutes, or whatever questions left, we'll answer them on the mails or by some other methods. And I thank very much to all my faculty and very much to the audience who have, cooperated with us in the initial glitch of IT as well. And they have stuck to us that long. And thank you very much to my team and to my IT team for helping us out to do this webinar. Thanks a lot to Dr. Reema, Dr. Rupali, and Dr. Mamta once again. Thank you so much.
Thank you, everyone.
Being a part
Thank
of
you,
it.
Christine.
Yeah, nice interaction.
Bye-bye.
Thank you so much.
Thank you. Thank you. Thank you.
Good day to everyone. Bye.
Yes.
Thanks.
Bye. Thanks. Bye-bye. Bye.
Thank you.
Thank you, audience, for your feedback.